Feeding or eating disorders. The International Classification of Diseases 11th Revision, ICD-11, grouping of feeding and eating disorders integrates ICD-10 eating disorders and feeding disorders of childhood, in recognition of the interconnectedness of these disorders across the lifespan. The ICD-11 provides updated conceptualizations of anorexia nervosa and bulimia nervosa to incorporate recent evidence, which eliminates the need for ICD-10 atypical categories. It also includes the new entities of binge eating disorder, which is introduced based on empirical support for its validity and clinical utility, and avoidant restrictive food intake disorder, ARFID, which expands upon ICD-10 feeding disorder of infancy and childhood. Feeding or eating disorders include the following: 6B80 Anorexia Nervosa, 6B81 Bulimia Nervosa, 6B82 Binge Eating Disorder, 6B83 Avoidant Restrictive Food Intake Disorder, 6B84 Pica. 6B85 Rumination Regurgitation Disorder. 7. 6B8Y Other Specified Feeding or Eating Disorders. Feeding and eating disorders diagnoses should not be used to classify low-level concerns related to eating or behaviors that are common or culturally sanctioned. General cultural considerations in feeding and eating disorders. 1. Weight and shape concerns are prevalent in many societies and dieting to lose weight is common. Cultural preoccupation with body weight and shape, for example due to global dissemination of body ideals through mass media, typically low weight in women and muscular physique in men, has contributed to increased rates of eating disorders in many parts of the world. The global obesity epidemic has also contributed to social concerns about eating and weight. Weight concerns and eating disturbances are more prevalent among men in some Asian and Eastern Mediterranean societies than in the Americas. For presentations characterized by abnormal feeding or eating behaviors that do not fulfill the diagnostic requirements for any other disorder in the feeding or eating disorders grouping, the diagnosis of 6B8Y other specified feeding or eating disorders may be considered. Let's start with 6B80 Anorexia Nervosa. Diagnostic requirements. Significantly low body weight for the individual's height, age, developmental stage, or weight history. A commonly used threshold is body mass index, BMI, less than 18.5 kilograms/m2 in adults and BMI for age under 5th percentile in children and adolescents. Rapid weight loss, for example, more than 20% of total body weight within 6 months, may replace the low body weight essential feature as long as other diagnostic requirements are met. Children and adolescents may exhibit failure to gain weight as expected based on the individual developmental trajectory rather than weight loss. 2. Low body weight is not better accounted for by another medical condition or the unavailability of food. 3. A persistent pattern of restrictive eating or other behaviors aimed at establishing or maintaining abnormally low body weight, typically associated with extreme fear of weight gain. 3. Behaviors may be aimed at reducing energy intake, by fasting, choosing low-calorie food, excessively slow eating of small amounts of food, and hiding or spitting out food, as well as purging behaviors, such as self-induced vomiting and use of laxatives, diuretics, enemas, or omission of insulin doses in individuals with diabetes. Behaviors may also be aimed at increasing energy expenditure through excessive exercise, motor hyperactivity, deliberate exposure to cold, and use of medication that increases energy expenditure, for example, stimulants, weight loss medication, herbal products for reducing weight, thyroid hormones. 4. Excessive preoccupation with body weight or shape. Low body weight is overvalued and central to the person's self-evaluation, or the person's body weight or shape is inaccurately perceived to be normal or even excessive. Preoccupation with weight or shape, when not explicitly reported, may be manifested by behaviors such as repeatedly checking body weight using scales, repeatedly checking one's body shape using tape measures or reflection in mirrors. Constantly monitoring the calorie content of food or searching for information on how to lose weight, or by extreme avoidant behaviors, such as refusal to have mirrors at home, avoidance of tight-fitting clothes, or refusal to know one's weight or purchase clothing with specified sizing. Specifiers for underweight status. In adults, very low BMI has been found to be associated with poorer long-term prognosis among individuals with anorexia nervosa, though it is not the sole determinant of medical risk. 6B80.0 Anorexia Nervosa with significantly low body weight. Anorexia nervosa with significantly low body weight. With BMI between 18.5 kg/m2 and 14.0 kg/m2 for adults, or between the 5th percentile and the 0.3 percentile for BMI for age in children and adolescents. 6B80.1 Anorexia nervosa with dangerously low body weight. Anorexia nervosa with dangerously low body weight, with BMI under 14.0 kg/m2 in adults or under the 0.3 percentile, fewer than 3 in 1,000, for BMI for age in children and adolescents. In the context of anorexia nervosa, dangerously low body weight is an important prognostic factor that is associated with high risk of physical complications and substantially increased mortality. 6B80.2 Anorexia nervosa in recovery with normal body weight. Among individuals who are recovering from anorexia nervosa who have achieved a healthy body weight, the diagnosis should be retained until a full and lasting recovery is achieved. 6B80.y Other specified anorexia nervosa. 6B80.z Anorexia nervosa, unspecified. Specifiers for the pattern of weight-related behaviors. Different patterns of weight-related behaviors among individuals with anorexia nervosa may be related to treatment selection and clinical management, as well as the course and outcome of the disorder. 6B80.x0 Restricting pattern. Individuals with anorexia nervosa who induce weight loss and maintain low body weight through restricted food intake or fasting alone or in combination with increased energy expenditure, for example, through excessive exercise, but who do not engage in binge eating or purging behaviors. 6B80.x1 Binge-purge pattern. The binge-purge pattern specifier should be assigned to individuals with anorexia nervosa who present with episodes of binge eating or purging behaviors aimed at getting rid of ingested food, for example, self-induced vomiting, laxative abuse or enemas. This type of anorexia nervosa also includes individuals who exhibit binge eating episodes but do not purge. 6B80.xz Unspecified. Additional clinical features. Anorexia nervosa. 1. Signs of low body weight may include visible or measurable signs of starvation, such as emaciation, lack of fat and muscle mass, extremities that feel cold to the touch or appear blue, hair loss, growth of fine lanugo hair, edema, proximal muscle weakness, amenorrhea, osteopenia or osteoporosis, slow heart rate, and low blood pressure. 2. An explicitly stated fear of weight gain is not an absolute requirement for the diagnosis of anorexia nervosa, provided that the behaviors maintaining underweight status appear to be intentional and there are other behavioral indicators of preoccupation with body weight or shape, for example, repeated checking or monitoring. 3. Individuals with anorexia nervosa often show a persistent lack of recognition about the seriousness of their condition. Medical risk among individuals with anorexia nervosa is not solely dependent on weight status. Medical assessment should take into account other important medical risk factors as part of a comprehensive physical examination. 4. Other risk factors include but are not limited to rapid weight loss, especially in children, orthostatic hypotension, bradycardia or postural tachycardia, hypothermia, cardiac arrhythmia, and biochemical disturbance. Boundary with normality, threshold. Course features. Anorexia nervosa onset during adolescence or early adulthood, i.e., between the ages of 10 and 24, typically following a stressful life event. Some individuals fully recover while many experience a chronic course. Severe symptoms of anorexia nervosa may require hospitalization. These are less likely to experience remission. 5. Most individuals diagnosed with anorexia nervosa experience remission within 5 years of onset. 6. Anorexia nervosa is associated with premature death, often due to medical complications of starvation or to suicide. Culture-related features. 1. In Asia, a subset of individuals with anorexia nervosa may not express fear of weight gain, sometimes referred to as fat phobia, as a rationale for reducing energy intake. Instead, dietary restriction may be attributed to gastrointestinal discomfort or to cultural or religious motives, fasting or dietary rules. The incidence of anorexia nervosa is greater in high-income countries. The prevalence of anorexia nervosa among men is increasing globally, and more men are presenting for treatment of the disorder. Sex and/or gender-related features. Anorexia nervosa is much more commonly diagnosed in females, 10-to-1 ratio, with a prevalence of 0.4%. Less is known about the true prevalence of anorexia nervosa in males. However, there is evidence that incidence and detection of anorexia nervosa in males is increasing. 3. The onset of anorexia nervosa is earlier in females compared to males. 4. Laxative abuse is more common among females, whereas excessive exercise is more common among males. 5. Males with anorexia nervosa are more likely to be preoccupied with being insufficiently muscularity, may exhibit excessive protein consumption along excessive exercise for maintaining low body weight or a low percentage of body fat. Please like and subscribe.